Good morning, students. So today's class will be on anatomical landmarks of maxilla. So what do you mean by an anatomical landmark and what is the importance of knowing the anatomical landmarks? So the anatomy of edentulous ridges, both in the maxilla as well as in the mandible, is very important for the design of a complete denture. Now, the consistency of the mucosa as well as the architecture of the underlying bone will be different in various parts of the edentulous ridges. This is the edentulous ridge. So the anatomy and the architecture will be different in different various parts of the edentulous ridge. So in order to properly construct a denture, one must understand the proper anatomy as well as the physiology of the edentulous patients. Now, what is the importance of these anatomical landmarks in the denture foundation? Why do you want to know about the anatomical landmarks? Because for selective placement of the forces as determined by the stress bearing potential. So these anatomical landmarks, for all we are seeing about the maxilla. So if in maxilla, only some areas will be capable of bearing the stresses, whereas other areas will need to relieve it. So to know where to give the force, we should understand the anatomical landmarks. Then second is the maximum coverage of the denture without interfering the health and function of the tissues. Again, we should not give pressure to those areas which are to be relieved, or in those areas where these nerves and vessels are passing. So we have to relieve and we have to cover the denture only in those areas which are capable of bearing the stresses. Then long-term success of the complete denture, also we have to know the anatomical landmarks. Now let's see what are the anatomical landmarks of maxilla. It is broadly divided into three. We have got the limiting structures, we've got the supporting structures, and we've got the relief areas. Limiting structures, as the name indicates, it limits the extent of the denture. So under the limiting structures, we have got labial frenum, labial vestibule, buccal frenum, buccal vestibule, hamular notch, and the posterior palatal seal area. Under supporting structures, it is broadly divided into two, the primary stress bearing area and the secondary stress bearing area. Now, supporting structures means they are nothing but those structures which are capable of bearing the stresses or bearing the load. Now, under the primary stress bearing area, we have got the horizontal antero and posterolateral heart palate and the lateral slopes of the residual alveolar ridge. And under secondary stress bearing area, we've got the rugae and the maxillary tuberosity. Now, next is the relief areas. Relief areas means these areas are not capable of bearing the stresses. So we have to provide a relief while taking the impression and while giving the denture. So why these areas have to be relieved? Because the nerves and vessels are passing through these areas. So if at all we give a pressure, that can lead to the paresthesia of the particular area. So the relief areas include the incisive papilla, the cupid eminence, the mid-palatine raphe, and the fovea palatinae. So when you come to the limiting structures, which are also called as the peripheral structures, and it is used to determine the peripheral seal for the denture border and also the optimum extension of the denture border. So these structures will determine the extent of the denture. Now, first one is the labial frenum. It is nothing but a fold of mucous membrane, and it may be single or multiple, narrow or broad. It has got no muscle fibers and get inserted in a vertical direction. Now, it is a passive frenum. The arrow mark denotes the labial frenum. It creates a V-shaped notch during recording the impression. Now, the clinical significance of this area is the frenum is quite sensitive to active movements, and the denture must be fitted carefully around it so that it can maintain a seal for the denture without any soreness. Second one is the labial vestibule. Labial vestibule is that portion of the oral cavity which is bounded on one side of the teeth, gingiva and alveolar ridge, and the other side it is bounded by lips and cheeks. The arrow point shows the labial vestibule. The muscle attachment of the labial vestibule, the main muscle is the orbicularis oris. Clinical significance of this area is the thick denture flanges may cause dislodgement of the denture, so it should be recorded correctly. Next anatomical landmark is the buccal frenum, which is a fold of mucous membrane, and it can vary in its shape as well as the size. So the muscle influences the position of the buccal frenum, so it has to be wider and greater to accommodate the denture. The muscle attachment here is the levator anguli oris, which is attached beneath the frenum, orbicularis oris, which pulls the frenum in the forward direction, and buccinator, which pulls the frenum in the backward direction. Now, buccal frenum, the adequate relief should be provided so that, as I mentioned before, it can be broad and great. So, adequate relief should be provided, otherwise it will cause dislodgement of the denture because of the movement of the muscle, buccinator muscle posteriorly and orbicularis oris muscle anteriorly. Then you have got the buccal vestibule. It is a space distal to the buccal frenum. So the area of the denture which will fill the space is called as the buccal flange. So the stability and retention is greatly enhanced if the vestibule space properly filled with the flange distally. Now, the boundaries of the buccal vestibule is anteriorly by the buccal frenum, posteriorly by hamular notch, laterally by cheek, medially by the residual ridge, and buccal flange of the denture will occupy this space. Then comes the hamular notch. The arrow point shows the hamular notch, which is nothing but a narrow cleft of loose connective tissue, which is located between the maxillary tuberosity and the pterygoid annulus. So this will determine the posterior border of the maxillary denture. Clinical significance is if it is short means the denture will have poor retention. If it is extended beyond means the patient, when the patient opens the mouth, the denture will fall down. Last one is the posterior palatal seal area, which is the soft tissue which is along the junction of the hard and the soft palate, where we can apply the pressure within the limit to aid in the retention of the denture. It is divided into two regions, pterygomaxillary seal and postpalatal seal. The main function is aiding in the retention, prevention of gagging, prevention the accumulation of the food, and compensates for polymerization shrinkage. And the posterior palatal seal area comprises of two vibrating lines, the anterior and the posterior. Anterior is recorded using Valsalva manual, and it is Cupid's bow shape because of the presence of the posterior nasal spine. The posterior vibrating line is recorded using R in a normal way, and it is that line is straight. Then we will move on to the supporting structures. Supporting structures, they are nothing but the load-bearing areas. We have got the primary stress-bearing area, which is the horizontal, anterolateral, possible antero and posterolateral hard palate and lateral slopes of the residual alveolar bridge. And the secondary stress-bearing area is the maxillary tuberosity and the rugae and the alveolar tubercle. These are called as the stress-bearing areas because they can bear the load. Now, rugae area is nothing but the raised areas of dense connective tissue, which is present in the anterior 1/3 of the palate, and they play a very important role in the phonetics while placement of the denture. Last one is the relief areas. So these areas have to be relieved because they resolve under constant load, and they include the incisive papilla, cuspid eminences, mid-palatine raphe, and the fovea palatini. Why are they called as the relief areas? Because they are more susceptible to resorption. They have got a thin mucosa directly over the hard cortical bone. Okay, so the mucosa will have neurovascular bundles. So if at all we give a compressive pressure, that can lead to the paresthesia of the nerves. In that first one is the incisive papilla, which is nothing but a pad of connective tissue lying between the two central incisors. It should be relieved. If not, it will compress the nerves and vessels, leading to the paresthesia of anterior palate. Next one is the fovea palatini, which is nothing but a coalesce of several mucous glands. So the denture can extend 1 to 2 mm beyond the fovea palatini. So this fovea palatini will have a secretion of thin film of saliva, which will aid in the retention. Next one is the canine eminence, which is rounded bony elevation on the corner of the mouth, which will guide in the arrangement of maxillary anterior teeth. Then we have got the mixed mid-palatine raphe, which is covered by thin submucosa. It should be relieved during the denture fabrication. It is the most sensitive part of the palate to the pressure. Last one is the torus palatinus, which is a raised bony ridge running down the center of hard palate. If it is small, it can be relieved in the denture. If it is too big, means it should be surgically corrected. Then your sharp bony spicules on the maxilla and the palatal bone. In resorbed ridges, these spicules may irritate the tissues between them and the denture waste, so it should be relieved. So to conclude, the real mantra of prosthodontia lies in the area of not only the meticulous replacement of what is missing, but also the perpetual preservation of what is present. So complete denture must function in harmony with the remaining natural tissues. So thus a successful complete denture can be delivered to the patient. So these are some of textbook references from which these slides have been prepared. Thank you so much.